So today, we're going to go through the anatomy of the foot and ankle. We're going to go through all the anatomy, and we're going to probably get to the lower leg. Probably not past, probably not to the knee. So what we're going to start with was foot and ankle, and there's going to be a lot of similarities between lower extremity and upper extremity. Some of the similarities are similar, but completely reversed in how we number the metatarsals and the phalanges. But a lot of similarities, so an awful lot of what we're going to talk about is a little bit of a repeat. So there's considerable differences in thickness of the foot. The foot is a wedge-shaped structure, and this really, what I'm about to say really doesn't correspond to a whole lot of clinical use now. But being a wedge-shaped structure, back in the days when we used screens and films, what we had to do on something that had a lot of differences in tissue thickness from one end of the anatomy to the other end of the anatomy is we had to, just like you do now, get a history on the patient. We had to select our technique based on where the patient's pain was, where the trauma was. So in something like the foot, where you've got thin toes and a thick heel, what you get, as the x-ray beam passes through the anatomy is attenuation. You're going to get more attenuation through the thicker portion, right? You get more absorption in the thicker portion of the anatomy, less absorption and more penetration in the thin portion of the anatomy. Kind of make sense? So when we were using films, what that meant was that one end of the image was going to be dark and the other image would be light. So if the patient had pain, let's say they dropped something heavy across the upper portion of the arch of their foot here, then you had to select a different technique for this portion of the foot than what you would have if the patient dropped something on their toes. Because if you shot with one technique, and the technique was high enough, had enough mass and KVP to get through this portion of the foot and give you a good density here, the toes would be burned. You couldn't see them. Not physically burned, but on the x-ray they'd be so dark you couldn't make a diagnosis. And at the same time, if you shot for a toe technique, the upper portion of the foot would be so light you couldn't make a diagnosis. So you had to select a technique based on what anatomy that you were interested in seeing. So what we had back then were different types of what we call compensating filters. And compensating filters do just that. They compensate for differences in tissue density or thickness, or in cases like the foot, or let's say the thoracic spine, where you've got a thin upper portion of your thorax and a thick lower portion of the thorax. Instead of having to select a technique for just that portion of the anatomy, what you could use was a compensating filter so that you could get an even technique or an even density between the toes and the proximal portion of the foot, or the upper and lower portion of the T-spine. So how we did that was we had aluminum filter, and the aluminum filter was also a wedge shape. So what we'd do is take the foot, wedge-shaped foot, and we'd take a wedge-shaped aluminum filter. We'll put the thick end of the aluminum filter, and it's not that thick, I'm exaggerating, it's maybe that thick, over the toes, and the thin end over the forefoot, over the arch or the heel portion. Okay, so this is a thing that's stuck to the collimator housing. So you position, and you get your light field just right, and the last thing you do is you'd attach this compensating filter to the housing so that whenever you made your exposure, what came through the filter was less down at the toe end and more up at the heel end of the foot, so that it evened out the tissue density differences. I say that it doesn't really have a clinical application now because your computer algorithm kind of does that for you. Have you ever seen a compensating filter or a wedge-shaped filter in clinicals? Probably not, because the computer algorithm is very efficient in giving you those densities. It's still a testable question, so on any kind of test that you take from now all the way until you graduate, if you have tissue density differences between one end of an anatomy and the other end of an anatomy, then a compensating filter, or wedge filter in this case, would even out the tissue density differences. There are other types that we didn't really talk about in upper extremity, but the same thing happened in shoulders. On a shoulder, what you would get in a lot of cases is light density on the sternal end of the shoulder, and maybe the greater tubercle will be completely burned out. So what they had for shoulders was what you call a boomerang filter, because it looked kind of like boomerang. It just kind of wrapped around the outer portion of the shoulder to even out the tissue density differences in the shoulder. So that's what a compensating filter is, and why it needs to be mentioned in feet, because of the tissue density differences and thickness differences between the proximal and distal portion of the foot. What we could use to even out that density difference on the image is a compensating filter. So we got 26 bones, and they're divided into tarsal bones, metatarsal bones, and phalanges, just like the hand, where carpal bones, metacarpals, and phalanges. In the feet, you've got tarsals and metatarsals. You've also got a couple of little bones here that are kind of marked by these little dotted circles, and those are sesamoid bones, kind of like what you had in your thumb. We'll take a look at those here in a bit. So you got 14 phalanges. You got 2 in the great toe and the big toe, and then 3 in the rest of them. And they're named by location, just like in the phalanges in the hand. Interphalangeal joints also named by location, just as they were in the hand. The significant difference is here we're going to go from medial to lateral in our numbering. So remember, in the hands we want 1, 2, 3, 4, 5 from lateral to medial. In the toes we're going to go from medial to lateral 1 through 5. Okay, why they do that? I don't know. Maybe it's a similarity between the thumb and the big toe. I don't know. I don't know why they did that. So everything else is the same though. If the patient were to drop something on any one of these joints, it would be the first, second, third, fourth, or fifth metatarsal phalangeal joint. If they were to drop something here, then it would be the second proximal interphalangeal joint and distal interphalangeal joint. Remembering that there's only 2 phalanges in the big toe. So you got 5 metatarsals instead of 8, as what we saw in the. I'm sorry, I'm thinking tarsals. You got 5 metatarsals. You got 8 metatarsals. You got, what is that, polydactyl. So 5 metatarsals, name 1 from 5 from medial to lateral. They are long bones, so they got a body and a shaft in the articular extremities. Proximal end is the base, distal end is the head. And then you got articulations, we just talked about those. So there, tarsal bones, there we go. 7 tarsal bones instead of 8. So the calcaneus, we tend to not think of the calcaneus as being a tarsal bone, but it is. It's your biggest tarsal bone, that's your heel bone. Directly on top of that, what you've got is the talus. And then you've got the cuboid laterally here, and then you've got 3 cuneiform bones, and they're just named by location. So you've got a medial, an intermediate, and a lateral cuneiform. Those are your tarsal bones. And an navicular. So again, the calcaneus is the largest tarsal bone, and it's also the one that's going to be fractured more commonly. We see a fair number of calcaneal fractures, very painful and kind of lasting are calcaneal fractures. I don't know that I've ever seen a fracture of any tarsal bone aside from the calcaneus and the talus. The rest of them, I don't know that I've ever seen one. So talus is directly on top of it. So you got calcaneus, and the talus is actually what articulates and provides that mainly hinge joint for the ankle joint itself. It's not truly a hinge joint in that it has some adduction and abduction as well, some little bit of other movement besides just pivot. And then cuboid, lateral, navicular, and the cuneiforms. So we had a mnemonic for the carpal bones. They also have one for the tarsal bones. If you go into clinicals and you ask anybody for the mnemonic for tarsal bones, they're not going to know it. Okay, so you know I don't even think that this showed up in Merrill's until either this edition of Merrill's or the one before. So if that helps you, that helps you. If it doesn't, then you know just memorize the bones. Y'all even know who Chubby Checker was? Mm-hmm. Yeah. Okay. Okay. I don't know. He may be dead. He may not be dead. All right, so the ankle joint is formed by articulation between the talus and the tarsal bones. On the lateral side and the medial side, what you've got are these big knots. You can reach down and you can feel your own ankle. So the big knot on the lateral side is what you call your lateral malleolus. Some people in clinicals will refer to it as a malleolus, whatever. And then on the medial side, you've got off the distal portion of the tibia, you've got a medial malleolus. So the actual articulation in the ankle, again, is primarily just your talus and those two bones, the tibia and the fibula. So it's a synovial hinge top joint. It allows flexion and extension, but it does allow a little bit of pronation, supination, a little bit more motion than just hinge. So slight abduction, adduction, and rotation motions of the ankle are in there as well. All right, so this is not an AP of the ankle. This is a little bit of an oblique ankle. What we call the ankle joint itself is a mortise joint. So the mortise joint is a joint that goes all the way around. It's articulation between the talus and the fibula. The talus superiorly and medially with the tibia is the mortise joint. So we'll take a look at that again here a bit. In a normal orientation, notice what we've got is some superimposition of the tibia over the fibula and some superimposition of the talus over the fibula as well. So sesamoid bones are, again, just bones that wherever we've got an area of acute bend, we might see some sesamoid bones. Some people will have sesamoid bones actually in the posterior portion of the ankle. It's what they call a normal deviation. You may see a sesamoid bone down here. But fairly well, everybody's going to have two sesamoid bones under the big toe. Okay? And those sesamoid bones are susceptible to fracture, or the tendons. Sometimes you get a lot of tendonitis in those tendons. Ever heard of turf toe? Okay, so dancers and high impact athletes like football players sometimes will fracture those, and that's what you're looking at is turf toe. It's very, very painful. And in a lot of cases, what they'll have to do is they'll have to go in there and remove portions of that if there's truly a fracture there. So very painful. Years and years ago, Deion Sanders, if you're football fans, anybody? Yeah, he was out for almost a whole season, it seems like, turf toe. That's exactly what it was. So there are small detached bones found in the foot, usually form in points of stress near a joint, usually found on the posterior plantar surface of the metatarsal phalangeal joint. It's possible to fracture one or both, and it's extremely painful. It lasts a long time. All right, so any questions on the anatomy? We'll go into the anatomy of the tib fib whenever we get to it. So, general procedural guidelines, again, just like in the upper extremity, you want to move the patient as little as possible. You know, if you're going to be shooting your extremity work, tabletop anyway, and they come to you on a stretcher, just leave them on a stretcher. There's no reason to put them on the table when they're already on a stretcher. It becomes a little bit more difficult if the patient's in a wheelchair to shoot them in a wheelchair, but you can get around it as well. So patient preparation is just like everything else that we've talked about so far. If it can come off the patient, and leaving it on the patient might provide some sort of artifact, or might give you an artifact, show an artifact on the image receptor, it needs to come off. That comes with a caveat that, you know, if the patient's got a brace or any kind of casting material or anything like that, then, you know, somebody else needs to take that off. We'll get into some specific fractures here in a little bit, that it becomes very, you know, hazardous to take casting material off or splint off the patient. So, patient position is going to be pretty specific. Most of the time it's going to be at least 2 views, possibly 3. What's your image receptor size? Your general rule for image receptor size?
If it's apart.
To fit the part, right? And your collimation is 2 things.
1 inch around the sides.
What's that?
1 inch around the sides.
Okay, 3 things, yeah. So you got about 1 inch, half an inch around the sides, make sure your collimator's not off. That's 1. Collimate to the part and never larger than the image receptor. Okay, very good, very good. Make sure you use your marker, make sure you use the correct marker, and follow the guidelines of the radiologist or hospital. Collimation is your main radiation protection, but there are some cases that it becomes even more important to use radiation protection in the upper extremity or lower extremity than the upper extremity. We'll talk about those when we get to them. You know, the patient again thinks that they're going to receive a great big radiation dose, so go ahead and put an apron on. The patient instructions are, for the most part, just to be still. So, shoes obviously have to come off, but the elastic in socks will give you an artifact as well, so they need to come off as well. You know, if you're dealing with blue jeans or anything like that, it needs to get out of the way as well. So ambulatory patients, if they come walking in, you can have them come in and hop up on the table. But if they're not ambulatory, just consider their comfort. You know, if they come to you on a stretcher, shoot them on a stretcher. If they come to you in a wheelchair, then use a little bit of discretion. You may have to put them on the table, you might not, depending on, you know, a number of factors. So SID for the most part is going to be 40 inches. You know, keep in mind that some of your textbooks say 48, but you know, most of the time it's going to be 40 inches. All right, so toes follow the same rules as fingers, and that is that you want to minimize your OID whenever possible. So this doesn't really play a part on the AP, but on the obliques and the laterals, certainly it does. But individual toes, where individual toes differ from individual fingers, is that in a lot of cases, you don't shoot individual toes. You know, you smash your finger or you jam your finger, can you identify which finger hurts? You kick a door frame, and where do you feel the pain? Yeah, your foot. It's, you know, you can say that whole side of my foot hurts, but you can't really say that toe specifically, right? You can say that toe hurts more than the other one, but you've got a big area. So in a lot of cases, and really every hospital I've ever worked in, we didn't do individual toes. We might do a lateral of an individual toe if we could see for sure that that toe was broken. But for you know, just general projection of the toes, it was all of the toes. Okay, so most of the time that's what you're going to be looking at. Your projections are going to be AP. Remember, AP on the foot is going to be dorsoplantar. The dorsal portion of the foot is the top of the foot. The bottom of the foot is the plantar surface. So you got 2 different terminologies for projection here. One is AP, anterior to posterior, and also dorsoplantar mean the same thing. Okay, so we're going to do it. AP, dorsoplantar, AP oblique, dorsoplantar oblique, and lateral. And lateral is going to be dependent on where the most likely pain is, medial side or lateral side. Okay. So collimation, 1 inch on all sides. All right, so you'll notice in the textbook and up here, it says AP or AP axial toes. A couple of things to point out there. In the hospital, you're not gonna hear anybody refer to AP axial toes. It's just gonna say AP toes, AP foot. But it's gonna be axial, okay? We just don't include the axial portion in most cases. Because we've got a wedge-shaped surface, wedge-shaped anatomy, what we want to minimize our distortion is we want to put the anatomy parallel to the image receptor, right? Can't really do that in this case because the foot is wedge-shaped. So instead of doing that, we're going to put the central ray perpendicular to the anatomy. Does that make sense? You can, you can use an angle sponge and elevate the patient's toes like that, but of course you got elevation of the toes, which gives you magnification, and increased OID and magnification. So in most cases, what we're going to do is just angle the central ray cephalic for both toes and feet. And that's to put the central ray perpendicular to the image receptor. Any angulation on the central ray is a axial, right? So even though in the hospital it says AP, your projection is going to be AP axial for both toes and feet, always, okay? So if somebody tells you to go in there and reshoot the AP, does that mean you go in there and you take the angulation off the central ray? The answer is no, because you're going to assume that they mean AP axial, okay? It's for both feet and toes. So the patient could be on the table, seated on the table, and bend the knee up so that you put the plantar surface of the foot in direct contact with the image receptor. So toes should be centered on the image receptor, and you're going to angle the central ray 15 degrees cephalic. So 15 degrees towards the heel. Even though the patient's here and their head is up here, right? This is still considered to be towards the head because it's more proximal. So it's going to be a cephalic central ray angulation. So 15 degree wedge sponge can be used if you happen to be able to locate one, but most of the time you're just going to angle the central ray 15 degrees cephalic. Okay. So it's axial, enters at the third metatarsal phalangeal joint. So again, a difference. If we were shooting individual fingers, where did we put our central ray? Interphalangeal joint, right? But on the foot, where we're going to put it is at the metatarsal phalangeal foot, third metatarsal phalangeal foot. So you're going to see all of the phalanges, every one of them, but you're going to put it at the metatarsal phalangeal joint for the same reason that you're going to shoot all of them. And that is, again, you get up and you kick the door frame in the middle of the night, and you know full well that you kicked it with your little toe. This whole portion of your foot hurts, right? You don't have quite as defined feeling in your foot as what you do in your hands. So in that way, you're going to, on toes even, you're going to include not only the entire toe, but about half of the foot as well. Okay? About the only thing that you're not going to see are the metatarsals. So, what if a patient's in a wheelchair? Can you shoot them in a wheelchair? Certainly you can, all right? In this case, really all you got to do is, and I'm not going to get that on the camera, but all you really got to do is make sure the floor is clean, but take your image receptor and put it on the floor and put the foot directly on top of it. You shoot directly into it, right? You don't have to get them on the table. The lateral becomes an issue. The oblique is not an issue. The oblique is really pretty easy to get in the chair. All you're going to do on the oblique is identify where the patient's pain is, and you're going to oblique them 30 to 45 degrees in that direction. Now notice you got a range here, it's 30 to 45 degrees. And what's going to determine that is the shape of the patient's foot. So you ever met anybody who's flat-footed? Truly flat-footed? Okay, some people have what they call fallen arches. Now, that's not flat-footedness. You take a look at somebody's foot and it truly looks like it's just, it's like a board and they have no longitudinal arch at all. That's flat-footedness. Okay, but if their foot is still wedge-shaped, then that's not really flat, right? It's wedge-shaped. So if they don't have much of an arch, you don't use much of an angle. If they have a big arch, you use more of an angle. Okay, so take a look at the patient's anatomy, and if they've got a wedge-shaped foot, you're gonna use closer to a 45-degree angle. If they're flat-footed, you're gonna use more like a 30-degree angle. So what you're gonna do is you're gonna oblique the foot and make sure that you explain to them, because if you just tell them, I want you to point your knee in that way, because of the adduction and abduction of the ankle, what you're gonna have is just this going on. Okay, so you need the sole of the foot to form that 30 to 45-degree angle. So, have the patient from their knee with the whole leg as a single unit, oblique in one direction. Okay? 30 to 45-degree angle, depending on the shape of the patient's foot. Okay? Now let's back up just a little bit. I'll show you what you see. All right, so in an AP, you notice, you should be able to see the distal portion of the metatarsals, or the metatarsals. Free superimposition proximally in. You've got, because you've got two arches, you got a longitudinal arch, but you've also got a transverse arch. What you've got is superimposition on the proximal end. So when you oblique, especially if you're going medial oblique, look what happens to the metatarsals on the lateral side of the foot. You see the way you get a decrease in superimposition? That's what you're gonna see. A lot of the fractures in your foot are gonna involve that pinky toe, because you kicked the door frame. But you've also got some fractures in the first metatarsal, or fifth metatarsal as well. You've even got fractures, there are revulsion fractures when you have no trauma to the foot itself, but sometimes people will twist their ankle and it'll break that little tubercle off right there. Condyle will snap straight off. I think it's called a Jones fracture. Sometimes it's an incidental finding. All right, so AP and medial rotation is not all that tough in a wheelchair. The lateral can be a little bit more difficult. On the oblique, all you gotta do is have a patient kind of kick up onto their hip and they can rotate. The lateral is a little bit more difficult. So lateral projection, if you're shooting in a chair, then in a wheelchair, you may have to shoot cross table lateral. All right, so for individual toes though, what we're gonna do for lateral is put the side of interest closest to the image receptor. So if you're looking at the big toe, you're gonna put the big toe down, right? So your projection, the big toe is gonna be up against the image receptor, so your projection is gonna be what? Image receptor is here, so that would be a lateral medial projection, right? It's still lateral, but it's lateral medial projection. You're shooting from the medial side into the lateral side. As opposed to if you're on one of these three, these two are gonna be with the medial side down, these three with the lateral side down, to minimize OID. So what you may have to do is to get a stool or something and a film holder and have the patient put their foot on the stool and shoot cross table for your laterals. You can leave the image receptor on the floor for the AP axial, and the oblique, but for the laterals you may have to shoot cross table. If they're on the table, on the other hand, you can just roll them up onto whichever side you need them to be on. So take those other toes out of the way, because unlike individual fingers, you can bend your individual fingers. Can you bend your toes individually? Maybe your big toe, but the rest of them, if you can, I'd like to see it, honestly. I've never met anybody who could move individual toes. So, anyway, you're gonna separate them. You may have to take the toes out of the way. Be real careful when you take the toes out of the way, because again, the pain is non-specific, and you start moving different toes around, you may increase the patient's pain. So just take them as far out of the way as you can get away with. Don't force them to bend their other toes more than what you have to. Okay? All right. So, any questions on toes? All right, then feet. really, the foot, everything that we talked about in the toes applies to the feet. With one notable exception we'll get to in lateral, but the AP is really AP axial. Again, you can use an angle sponge if you want to. The AP oblique is just like the AP oblique of the toes. It's just our central ray location collimation is going to be much larger, and the lateral, we've got a couple of things we need to identify. So positioning is identical. You can do it on the table. The one notable difference between toes and feet is on toes, we're going to angle 15 degrees. On feet, we're going to angle 10 degrees. Okay? So that's the only real difference, 10 degrees as opposed to 15 degrees, and it's just central ray location collimation. All right? So medial rotation, again, is the same in that you've got 30 degree to 45 degree oblique. Now watch what happens to both the toes and the foot when oblique. All right, so you got PA and you got your 15 degree angulation for the toes, you got a 10 degree angulation for the foot. But when you oblique, what happens, the purpose for that angulation is two things. Put the central ray perpendicular to the anatomy, that's number one. And number two, to put the central ray parallel to the joint spaces. All right? So when we oblique, what happens to the orientation of the toes as opposed to what would be the image receptor? Do we have that same steep angulation here as what we had here? No, they've become more parallel, right? So they're horizontal, fairly well horizontal. Do we need that angulation for the obliques? No. So in both the toes and the foot, what we're going to do is we're going to use the angulation for the AP, so it's AP axial, but the oblique is not. Oblique just uses a perpendicular central ray because the anatomy becomes parallel with the image receptor, or more parallel with the image receptor. Okay? So it's foot centered to the middle of the image receptor. What you're not going to see really on the AP of the foot, especially, but less so on the oblique of the foot. You'll actually see a portion of the calcaneus, but on the AP, we're just not going to see the calcaneus very well. So again, calcaneus being the most common fracture of the tarsal bones, we're going to shoot some specialty views of the calcaneus. We'll get to those here in a bit. So lateral of the foot, a couple of things on lateral of the foot. You can shoot the lateral of the foot either medial lateral or lateral medial. Most of the time people are going to shoot them medial lateral because it's easier for the patient. If you have the patient just roll up onto their side, what's going to happen with the foot in a lot of cases, especially if they kind of point their toes, is they're going to supinate their foot. The bottom of the foot's going to be pointing just a little bit towards the sky. Okay? So on your lateral foot, if you're rolling the patient onto the side affected, so that the lateral side is down, what you need to do is dorsiflex the foot. Dorsiflex means to pull the toes back, not point the toes, pull the toes back until they're at a 90-degree angle. And what will happen is that supination of the foot will straighten out. Okay, so you'll get more of a true lateral of the foot. Every textbook that you're ever going to see is going to have some sort of reference to shooting the lateral foot with medial side down. And the reasoning behind it is to put the broad base of the medial side of the foot in contact with the image receptor, and it gives you a more broad surface to put it on so that this becomes less of a problem. Okay? You put the fat side of your foot down and you get a more consistent lateral. Okay? Is it still lateral? Yeah, absolutely. It's still lateral projection, right? It's just lateral medial as opposed to medial lateral. The problem here is getting the patient into this position because this knee is going to have to be in contact with the image receptor, which is going to be a little bit more difficult to have the patient accomplish. It can be done, but the textbook and test questions will refer to putting the medial side down to get a more consistent lateral. And the broadness of that base is the primary reason for that, but secondarily, what we're looking at is a difference in magnification. So on a medial lateral projection, we're putting the fattest anatomy furthest away from the image receptor to get more magnification, right? On the lateral medial, we're putting the fattest anatomy closest to the image receptor, so we're not going to have as much magnification. So it's going to appear a lot thinner, okay? So a couple of different reasons for that. One is to overcome that magnification, but also to provide that broad base. So what you're going to be looking for on test questions is to get a more consistent lateral on the lateral foot. Which surface do you put down? Medial side, right? But most people, and probably most of the time, you're going to shoot with the lateral side down, and that's fine. Just make sure you dorsiflex the foot to 90 degrees if the patient can do it, and you know, make sure that they're not supinated, so that the difference in the appearance of the metatarsals on lateral are going to be dorsiflex 90 degrees, not dorsiflex. Okay, so you just not lateral is what you wind up with. So those things on lateral foot pertain to lateral ankle and also calcaneus as well. Medial side down, more consistently get a good lateral. So your central ray is going to be perpendicular to the base of the third metatarsal for the lateral foot. Whenever we get into lateral calcaneus, again, the only difference is going to be central ray location collimation. Lateral ankle, just central ray location collimation. Everything else is identical. Okay. Any questions on feet? So the important things to remember is all toes, right? All toes. Toes 15 degrees, feet 10 degrees, medial side down for a more consistent line. All right, so calcaneus, what we're going to have is an axial planto-dorsal projection. So planto-dorsal is going to come through the bottom of the foot and out the backside. Okay, it's not going to come out of the top of the foot, it's actually going to come out of the backside of the foot. And a lateral. All right, so a couple of things about broken calcaneus or suspected broken calcaneus. You've got your Achilles tendon hooks into the backside of your calcaneus, okay? So what the Achilles does is it goes up and it attaches to the gastrocnemius muscle. So you got, you dorsiflex your foot, you pull your foot back, what do you feel if you pull it back far enough?
Hamstring.
You feel a lot of tension, right? So what we're going to be asking the patient to do is dorsiflex the foot, and if in you dorsiflexing your foot, over dorsiflexing your foot, you feel that tightness right there, then what do you suppose is going to happen if the patient's got a broken calcaneus and then dorsiflex their foot at all? You think it's going to be pulling on those broken fragments? Answer is yeah. So it's going to be very painful for the patient. So you've got to allow the patient to participate at their pain level, right? Because what we're going to ask the patient to do is dorsiflex their foot to 90 degrees, to right here. They're going to come in and their toes are going to be pointed like that, and we're going to ask them to pull their toes back as far as they can. Encourage them, tell them you need them to do this, but if they say that's as far as I'm going to go, are you going to reach down, grab their foot and say, no, it's not? No, you're not. So ask the patient to pull back their toes as far as they can. You can even give them something to wrap, a piece of gauze or something to wrap around the bottom of their foot to pull with their arms and maybe get a little bit more dorsiflexion. But don't force them to do anything. All right? So The ankle should be dorsiflexed so that it's at a right angle. The foot is at a right angle from the leg. The ankle should be centered to the image receptor. We're going to use a 40-degree cephalic angulation. It's going to enter at the surface of the base of the third metatarsal. So we keep talking about the base of the third metatarsal. It's going to be tough to visualize exactly where the base of the third metatarsal is on this one. But really, if you go out laterally, you know, you got here, base of the third metatarsal, you go out laterally, that's pretty much where the knot on the lateral side of your foot is, right? Where the big tubercle is. So if you just go in medially from that to the center of the foot, that's what you're looking at, is the base of the third metatarsal right there. So dorsiflex the foot. You use a 40-degree cephalic angulation on your central ray with your image receptor, keeping in mind that the center of your collimated field at that 40-degree angle is going to be right here, okay? You put the middle of the image receptor down there, you're not putting the anatomy in the center of the image receptor, right? So with that angulation, you may have to center your image receptor a little bit higher than what would be intuitive. But 40-degree cephalic angulation. If the patient can't dorsiflex that far, then what you're going to do is just increase your angulation. Okay? You're going to try to keep that relationship the same. Does that make sense? Okay. So try to get them to 90 degrees, 40-degree cephalic angulation if they can do it. If they can't do it, just increase your angulation and try to show the same thing. So lateral calcaneus, again, most of the time you're going to shoot with the patient on the affected side, but the same thing applies. You know, more consistent lateral on all this stuff is with the medial side down. Probably not going to do that. You're just going to put the lateral side down. Okay, so resting on the affected side, the leg almost lateral. Again, dorsiflex foot to make sure you get as close to a lateral as possible. Calcaneus center to the image receptor, perpendicular in this case. You're not going to use that 40-degree cephalic angulation. My allergies wearing me out. And that's your lateral. Okay. Any questions on calcaneus?
Even if they come in the ER and it's obviously very broken, are you still gonna try to get them to get that?
Just, yeah, I mean, yes is the short answer. The long answer is you know, you're gonna take what you can get. You know, you ask the patient to do it, and the fractures of the calcaneus, oddly enough, are not all that obvious. Because what's gonna happen with calcaneus is it's gonna fragment. So you know, it's gonna have multiple fracture lines through it. So looking at it, you're just not gonna be able to see it. It's not going to be deformed like a long bone would be, you know. But still, you know, try to talk the patient into dorsiflexion if they can, and if they won't, then. That's a quick story. There was I used to work in surgery, and there was a CRNA that it was coming up to Christmas one year, and they were just starting with landscaping companies, putting up Christmas lights. You know, in the wintertime they'd start to put up Christmas lights because grass doesn't grow. And so this guy, he was just going on and on. You know, people were paying like $1,000 to have the Christmas lights put up. They'd come out and they'd put them up, and then at the end of the season they'd come out, back out, and take them down. He was just going on and on about not paying somebody to put his Christmas lights up. He said, "I do it myself." So he was out putting his Christmas lights up. It was wet, and he had his ladder on the driveway because he was going across the driveway right there by the garage. It was wet, and the ladder got out from under him. He fell. He landed on his feet, but he broke both calcaneus. Both of them. Oh, I want to see him in the hospital. Bet you're wishing you'd have had somebody, you know, paid somebody to put your Christmas lights up. Shut up, man. So, anyway, very painful, and it takes a long time to heal. The thing about foot fractures, anybody ever had one? Any kind of foot injury, true foot injury? they heal in about 4 weeks. The pain doesn't go away for about 6 months. So,
My dad broke his last year and he still has pain. He still
Yeah.
has a little pain.
yeah, they hurt for a long time. All right, why don't we take a break? We'll come back and we'll get into ankle.